Everyone, I would like to thank Dr. Devi ma'am and KMC Institute of Radio Diagnosis for giving me this opportunity. This is my disclosure. I do not have any actual or potential conflict of interest, and I've used copyrighted material with and without permission, but it's only for the purpose of teaching. Okay, we'll start with the basics. First one, is this a normal X-ray? Is this a normal cardiothoracic ratio? What is transverse cardiac diameter? What is the normal dimension of right descending pulmonary artery? And which structures form normal cardiomediastinal contour? Is the cardiothoracic ratio normal in this? Yes, it's normal. Okay, you measure cardiothoracic ratio by measuring the largest dimension of the heart and the largest diameter of the thoracic cage and divide them. It's usually less than 50 is fine. 50 to 55 is acceptable. More than 55 is not acceptable in adult age group. For pediatrics, it's acceptable till 55 to 60 is fine. What is transverse cardiac diameter? Transverse cardiac diameter is the largest dimension of the heart on the X-ray. The normal dimensions are 15.5 centimeters for the male and 14.5 centimeters for the females. Rather than the dimensions, yes, sudden increase in the diameter by 1.5 centimeters on two consecutive chest radiographs taken close to each other can be a sign of cardiomegaly. Next question, what is the normal dimension of right descending pulmonary artery? Normally the dimension is less than 16 millimeters in males and 15 millimeters in females. 16 millimeters in males and 15 mm in females, and it's measured at the widest point just above the bifurcation of the right descending pulmonary artery into lobar and middle lobar arteries. Which structures form the normal cardiomediastinal contour? What is this formed by? What is the right heart border formed by normally? Pardon? Right atrium. Right atrium forms the right heart border and the left ventricle forms the left heart border. There should be no confusion on this. This is the normal cardiomediastinal contour. Your left atrium and normal left atrium and the normal right ventricle do not have any role in the mediastinal contour in a normal heart. Whenever you see the left atrium or a right ventricle, that is a pathological heart. Okay. This is a 57-year-old male with chest pain. What are the findings? What are the causes and the differential diagnosis? What are the findings? Pardon? Pericardial effusion. Why do you say it's a pericardial effusion? Okay. Nice. It's a dilated heart with a water bottle shape appearance. It's classical for pericardial effusion. Normally is there fluid in the pericardial sac? Yes, we have around 30 to 50 ml of fluid in the pericardial sac normally. At least 200 ml should be present in the pericardial sac for it to become radiographically visible. Okay, these are the classical findings of pericardial effusion. The enlarged heart with the flask of water bottle configuration. How do you differentiate this from, what are the differential diagnosis? What can be the differential diagnosis? For enlarged heart, what do you think commonly? Cardiomyopathy and a multivalvular heart disease. How do you differentiate them? How do you differentiate a pericardial effusion from these conditions? Okay, you normally expect for these conditions for your multivalvular disease or a dilated cardiomyopathy, expect pulmonary congestion which will be associated with heart failure. Whereas in a pericardial effusion, we do not see pulmonary plethora. Instead, we are seeing a pulmonary oligomeal. Don't see much of vessels, and the shape of the heart is useful again. And on the lateral view, you can see a classical displacement of the precardial fat. Okay, the effusion is seen pushing the precardial fat posteriorly. This is seen on the lateral view. And what are the causes for pericardial effusion? Common ones. Common ones would be post-viral, tuberculosis, trauma, METS, lupus, post-MI, and uremia. This was a case of uremic pericarditis with pericardial effusion. Okay, this is a 20-year-old male with shortness of breath. What are the cardiac findings and signs found here? What are the other radiological findings other than cardiac? What are the diagnosis and what are the types? Anyone? Pardon? TOF, huh? Why TOF? Why TOF? Okay, anything else? Boot shape, but it's not the classical boot shape. We'll see a boot shape dart soon. See the aortic contour, you see any abnormality? Aortic contour, is that fine or is there any abnormality? Okay. You see a figure of 3 appearance. There is a slight indentation in the aortic contour. Okay. In the aortic arch contour, there is a slight focal indentation. It's a classical figure of 3 appearance. Okay, it's seen in around 50 to 65% of adults with aortic coarctation. The upper curve of the 3 is formed by the subclavian artery, left subclavian artery, and the aorta which is proximal to the coarctation, and the lower half is formed by the poststenotic dilate aorta. And what are the other findings seen? Is there any other finding? What else do you expect? Okay, this is a barium left anti-oblique view. What do you expect to see on this? We see a reverse figure of 3 on this. Okay, the indentation is causing the aortic coarctation is seen indenting on the barium column and producing a reverse figure of 3. And on the aortogram, you see again a nice coarcted segment. It's a focal coarctation with a pre-stenotic and post-stenotic dilatation. What are the other radiological findings? Next thing you have to look for is classical rib notching. Do you see the rib notching? It's nicely depicted here. Where do you expect to see the rib notching? Lower quarter of the ribs. Which ribs? All the ribs are involved, or some ribs are spared? Okay. Why are they spared? Okay. Inferior rib notching is called as Rossler's sign. It is due to the dilated intercostal vessels. It's usually it's a sign of a long-standing disease, and it's not seen in infancy, and it's very, very unusual to see in patients less than 5 years. It's seen in 70% of patients, older children or adults who present with coarctation. Okay. It usually involves 4th to 8th ribs, and 3rd to 9th ribs may be involved. The 1st and the 2nd ribs are not involved. The reason is important. The 1st and 2nd post-intercostal arteries arise from the costocervical trunk, which is a branch of subclavian, and they do not communicate with the aorta. So these are not involved in collateral formation. It's important to remember the reason for absence of collaterals in the 1st and the 2nd ribs. And the collaterals, the rib notching can be either unilateral or bilateral. We'll come to that. Okay, what are the types? Types will be preductal and the postductal. Okay, what is preductal and what is postductal? What is the difference? You don't have to take images. I'll share the entire PowerPoint with you. Don't take images. I'll share it with you. You can give me your email. I'll share it with you. Don't take images. What is the difference between infantile and adult form? What is preductal and postductal? Okay, whether the obstruction is before the duct or either it's before the duct or it's after the duct. What difference does it make actually? That's the primary difference for collateral formation. Preductal ones, which ones have collaterals? Preductal or postductal ones? Pardon? Postductal ones have collateral formation. When do the collaterals form? After the birth or before the birth? After the birth, huh? Or before the birth? When do the collaterals start forming? We don't see rib notching in infancy or in less than 5 years, but when do the collaterals start to form? Collaterals start to form in utero. Okay. Why you don't have collaterals in preductal form? Another way to pose the question: why you don't have collaterals in preductal form? Yes, very good. The PDA takes care of the aortic supply, so there is no chance or necessity for collateral formation in a preductal form. Okay, that's why the preductal ones they present early. they present early with systemic hypertension or failure to thrive. Whereas the postductal ones, they have already established collaterals which help them survive or present till late childhood or adult age group. Okay. Coarctation is a common disease causing around 5 to 8% of congenital heart disease. These are the associations. We'll skip them. The common things you have to remember is coarctations are known to be associated with intracranial Berry aneurysms, and syndromic Turner is a very common association with coarctation of aorta. And the imaging differential diagnosis would be pseudocoarctation, where there will be only elongation, narrowing, or kinking, but there will not be any pressure gradient, there will not be collateral formation, there will not be any rib notching. And other one would be a chronic phase of Takayasus. Okay, these are three patients who have all of whom have the same condition. What is it? Same disease, but three different patients. What is this? Pardon? Okay. What are the types? Sometimes the questions or the clues. What are the types? What are the complication? What are the most common congenital heart disease? Sometimes the questions are the clues. Pardon? What is common in all of them? Dilated pulmonary arteries. You see, what is it called as? What is it? The dilated pulmonary arteries, what is it? It's called as a shunt vascularity. It's a prominent shunt vascularity, and there is cardiac enlargement. These are all classical examples of ASD with ASDs of different severity and different duration. Okay. What are the complications? Complication of any left to right shunt over a period of time. At the end, they can develop Eisenmenger syndrome. Okay. This is a marked enlargement of pulmonary artery secondary to Eisenmenger syndrome. Okay, ASDs are the second most congenital heart disease after VSDs, and they are the most common to become symptomatic in adulthood. They present a little late because of the low pressure involved in the shunts. Okay. Go to the, these are the associations with the ASDs: Downs, Voltorum, Salis, Van Crevel, Leutenbacher, and anomalous pulmonary venous return. What are the types? These are the types: secondum, primum, sinus venous ASD, coronary sinus ASD. Sometimes people involve patent foramen oil as a type of ASD. The commonest is the ostium secondum type, and the next would be ostium primum. Primum type would be more associated with congenital condition, chromosomal conditions like Downs. This is a brief overview of the atrial septal formation and the atrial septal defect locations. I think I'll skip that. Appearances. The appearance will be quite normal in early stages when the ASD is small. Over a period of time, when the shunt is larger or the child grows, there are signs of increased pulmonary flow, which is called the pulmonary plethora or the shunt vascularity, which is enlarged pulmonary vessels, upper lobe vessel prominence, visibility of vessels in the periphery of the films, and eventual signs of pulmonary arterial hypertension. And one thing you have to keep in mind is the chamber enlargement. The left atrium is normal in ASD, unlike a VSD or a PDA. That is the important differentiating point. Though right atrium and the ventricle are enlarged, left atrium is normal in the ASD. Complications would be, as we said earlier, it's the pulmonary hypertension eventually develops. Other complications would be development of paradoxical emboli and cardiac conduction defects. This is a companion case. What is it? Same ASD. What is this? ASD. It's a ASD with a percutaneous closure device. That star-shaped thing is the ASD closure device. Another one. This is another ASD with a Amplax closure device. What are the common congenital heart disease? Congenital heart disease incidence around 8 to 9 per thousand live births, and the commonest would be VSD followed by PDA and ASDs. Okay, all these three constitute around 50% of the congenital heart disease. So VSD followed by ASD and PDAs. Okay. Okay, this is a 30-year-old male with shortness of breath. What are the findings and the diagnosis? What is the clinical importance of the structure initially? In which circumstance that structure is essential for prolonging the life of the patients? What are the findings? It's quite obvious. Okay, it's a very large patent ductus arteriosus. Okay, the MPA is dilated, relative to the ascending aorta. There is an enhancing tubular structure in between the proximal descending aorta and the main pulmonary artery, and the descending aorta is enlarged relative to the ascending aorta, and there is also asymmetric contrast enhancement between the ascending and the descending aorta, okay, due to the altered pulmonary artery pressures related to systemic pressure, okay. You see the ascending aorta is less enhancing than the descending aorta because of shunt from the pulmonary artery. Again, the coronal and sagittal reformers demonstrating the PDA, a very large PDA. What is the clinical importance? What is the clinical importance of PDA? Why a PDA is essential in a fetal circulation? Okay. Lung doesn't have much of role in the fetus. Okay, lung doesn't have any role. Lung doesn't. There does not need to be a lot of blood flow for the lung. It primarily helps in bypassing the high resistance pulmonary circulation. That is the primary role of the PDA. Okay. What are the conditions that can cause early closure of PDA? What can cause early closure of PDA? Premature closure of ductus can occur with maternal use of NSAID. Okay, the duct usually closes functionally within the first 18 hours, and it fully closes several weeks later. And in premature infants, the patency can be seen up to 10 days after birth. Some consider patency abnormal only after 3 months of age. Okay, but beyond that, PDA is not going to close, and it can cause pulmonary hypertension and Eisenmenger syndrome. Finally, in which conditions the PDA is essential? PDA is essential in these conditions: tetralogy of Fallot, and already developed Eisenmenger syndrome, a hyperplastic left heart, and a pulmonary arteries. In all these conditions, the patent ductus arteries is essential for prolonging of life. Okay, this is another companion case. What is it? It's a case of PDA. What is this? What is the radioplasty? How is it treated? Patent ductus arteries. How do they treat? Okay, it is a PDA coil. Okay. Another case, another companion case. What is this? It is again a large PDA. And what is that arrow showing? What is this? There is a triangular calcification within it. What is it? It's a calcified PDA. What is the importance? Whenever the ductus is calcified, these percutaneous closures cannot be done. Okay, this calcified ductus requires ligation and division with cardiopulmonary bypass. So calcification precludes percutaneous management, needs open surgery. Okay, it's called as a classical inverted Y shaped in a calcified PDA. Okay, this is a 5-year-old male with bluish discoloration of fingers. What is this? Pardon? Egg on string. I have left the egg on string. It's not the egg on string. What else can it be? What is missing? What is this? Okay. What else? What else looks like an egg on string appearance? Egg on string basically means a narrow vascular pedicle. What else can have narrow vascular pedicle? Or just with the clinical history, take a guess. A 5-year-old child with discoloration, bluish discoloration, what all will you think? What are the congenital heart diseases? Otherwise, what are the congenital cyanotic heart diseases? Okay, this is a boot-shaped heart. This is a classical boot-shaped heart with a concave pulmonary segment and a upturned cardiac apex. This is the classical boot-shaped heart. What are the components of a tetralogy of Fallot? You have a VSD. Okay, you have a VSD, infundibular pulmonary stenosis, overriding aorta, and a right ventricular hypertrophy. Okay, these are the 4 components of tetralogy. What is triology of Fallot? What is triology and what is pentology of Fallot? Okay. Triology is just a pulmonary stenosis with RVH and a patent foramen hole. You don't have a VSD. Pentology is TOF plus a ASD. And TOF is the commonest congenital cyanotic heart disease. Okay, this is a 2-year-old male with shortness of breath and cyanosis. what is the diagnosis, what are the findings associated with this condition, and if MRI is done, what to report on it, what to report on MRI. Classical. How is the heart? Normal or large? Large. Okay. Cyanotic heart disease with a large heart, what do you think? There is marked cardiomegaly. Pulmonary, there is no shunt vascular, you don't see much of pulmonary vessels. There is decreased flow. Cyanosis, you always think of a Epstein's. Whenever there is a marked cardiomegaly, decreased pulmonary flow and cyanosis, always think of Epstein. Shows a classical box-shaped heart. Okay. It's a classical Epstein's. Epstein's, what is the pathology, basic pathology? There is dysplasia of the tricuspid valve leaflets and displacement. Dysplasia and displacement. There is downward displacement of the septal and the posterior leaflets towards the right ventricle. Your right atrium becomes very large and the right ventricle becomes smaller, and there is a lot of tricuspid regurgitation. Okay, again this is a pictorial representation of diagrammatic representation of the Epstein's anomaly. Okay, there is displacement, downward displacement of the tricuspid leaflets, and your right atrium becomes quite large, and there is a ASD associated with it. MRI, sometimes in MRI is done. You have seen MRI is similar to echocardiography. Always look for the apical displacement of the septal and posterior leaflets of tricuspid valve. If the tricuspid attachment is more than 1.5 centimeters beneath or that is towards the apex, it is usually considered Epstein's. You always look for atrialization of right ventricle, look for tricuspid regurgitation, and mention the right ventricular volume. See what just mention what is the volume of heart, that is below this downward displaced septal leaflets, sorry, tricuspid leaflets. 8. This is a 1-year-old male with cyanosis and congestive cardiac. Pardon? Snowman. Okay, what is the diagnosis? What is the imaging sign? You already told me. What is the diagnosis and what are the types? TGA. TGA, TAPVR. TAPVR, okay. What are the types? Supracardiac, cardiac and infracardiac. Other is mixed. What is the pathology? What happens in a TAPVR? Okay, what happens in a snowman? You get in which type of TAPVR? You get it only in a supracardiac TAPVR. Okay. What causes the snowman? What is causing the snowman? Okay, you have the right and left pulmonary veins. Normally expect them to join where? Left atrium. Okay. So what has happened here? Instead of it, it is formed a common pulmonary vein, which in turn forms a vertical vein, and which is draining into the left brachiocephalic vein, and then goes to the SVC. Now you can tell me what forms the snowman. This portion forms the snowman, which is the common pulmonary vein, vertical vein, and the left brachiocephalic artery forms the head of the snowman. Okay. Okay, the type is it's cyanotic heart, congenital heart with abnormal drainage anatomy. This contrasts with what is the other type? Other type is the partial anomalous pulmonary venous return, where only part of the pulmonary circulation is abnormal, other part is normal. Okay, in TAPVR, all the systemic and pulmonary vein returns to the right atrium and nothing drains the left atrium. So a right to left shunt is very essential. Okay. Okay, as you already said, supracardiac is the most common type. It constitutes around 50% of the cases. Next is the cardiac, where the pulmonary veins connect to the coronary sinus. Infracardiac would be the connection of the pulmonary veins joined behind the left atrium to form a common descending vertical vein, which joins the IVC. Okay, in supracardiac it joins the brachiocephalic and SVC. Here it goes beneath the diaphragm and joins the IVC. Does this type cause cardiomegaly? Infracardiac TAPVC, does it cause cardiomegaly? Cardiomegaly occurs only in type 1 and type 2. Type 3 or infracardiac TAPVR does not cause cardiomegaly. Okay. Remember, supracardiac variant can only cause a classical figure of 8 or a cottage loaf heart. And as I said, the relative vertical vein and brachiocephalic vein, and the SVC form the head, and the body of the stenomen formed by the enlarged right atrium. This is an additional case again showing a figure of 8, but not figure of 8, but not as classic as the original case. Okay. This is a 5-year-old male came for whose radiograph was taken for evaluation of 1 week of fever. What is the diagnosis? What is the finding and the types? Okay, it's a classically you are seeing a curvilinear opacity in the right paracardiac region, which is going below the right diaphragm. It's a classical scimitar. What is a scimitar? Scimitar is a Turkish word. Okay. What produces the scimitar? Okay. Okay. Part of the pulmonary venous drainage goes below the diaphragm and joins the IVC. Okay. It's an partial infracardiac pulmonary venous return. It is associated with ipsilateral pulmonary artery hyperplasia and ipsilateral lung hyperplasia, and there can also be aberrant systemic supply to the ipsilateral lung. Aortopulmonary collaterals can be seen, and you often have dextrocardia associated with this syndrome. These are the types. We'll skip this. Left side is more commonly reported in adults, and the right side is more commonly reported in children. Okay. I have 5 more minutes. I have 2 more cases. Okay, this is again a companion case showing a scimitar sign, PAPV, partial anomalous pulmonary syndrome with a with the scimitar syndrome. Okay. This is a 30-year-old male with dyspnea and exertion. What are the findings? Diagnosis? Are there any findings on barium study? And what is Lutembacher syndrome? Findings? There is moderate cardiac enlargement. There is straightening of the left heart border. There is, I think the window is not proper, but you can see a left atrial heart. You can see a double heart appearance, and I don't know whether it's very appreciable. You can see some curly B lines in the right lower zones. Okay, left atrial enlargement has 4 characteristic features: a double atrial shadow, straight left heart border, elevated left main stem bronchus, and a posterior displacement of the cardiac silhouette. Okay, what happens on a barium? Barium, because of extensive left atrial dilatation, it's closest to the esophagus, so it causes the mid-esophageal indentation. And mitral valve stenosis may be congenital acquired, with the latter being more common in our country, but congenital MS can also account for 0.5% of congenital heart disease. And what is Lutembacher syndrome? Lutembacher syndrome was initially ASD with the acquired MS, but current consensus define Lutembacher syndrome as any combination of ASD, either can be congenital iatrogenic with MS, which can be congenital acquired. Any origin, a combination of ASD and MS is Lutembacher syndrome, and typically the ASD is more than 15 mm in a Lutembacher syndrome. The last 2 ones. This patient has had multiple cardiac surgeries. What are the prosthetic cardiac valves? How do you identify them? Any guesses? Which is the topmost one? What is this? Can we identify them or just topmost will be? Okay, here which prosthetic valves? Almost 4 are there, so all the 4 valves are replaced. So which is which? That is the question here. How do you identify them? How do you identify them? Do you know the lines that have to be drawn? Okay, the topmost one is the pulmonary one, pulmonary, aortic, mitral, and tricuspid. Okay. How do you identify them? On a lateral view, draw a line from the carina till the cardiac apex, and on a frontal film, you draw a line from the left atrial appendage towards the right cardiophrenic angle. Whatever is above is what the valves that are above these lines are the pulmonary and the aortic valve. Whatever is below is the tricuspid and the mitral valve, and the superior most one is the pulmonary valve. The inferior most one is the tricuspid valve. Okay, these lines are very important and useful in differentiating. You should not confuse between aortic and pulmonary and mitral and tricuspid. You can always draw the lines. Whatever is above is aortic and pulmonary. Whatever is below is tricuspid and mitral. And tricuspid is the lowest, usually the lowermost, and is closest to the diaphragm. Okay, again a reiteration of the same thing. Okay, it will be pulmonary, aortic, mitral, and tricuspid on the frontal view. The last one, what are CIEDs? Can you identify the different CIEDs? What are the complications and how do you assess their integrity is the last one. What are CAEDs? Pardon? They are cardiovascular implantable electronic devices. What constitute them? Cardiac pacemakers, implantable cardioverter defibrillator, cardiac resynchronization therapy, ILR, and intravascular cardiac monitors. Okay, which is which among this? Any guesses? What is A? A? What pacemaker? All are different. 5 are there. All 5 are different. Which is which? Okay. All the conduction devices have 2 major components. One is a pulse generator and the lead wires. This one. This is a single chamber ventricular pacemaker. You see here, see the tip in the right ventricle. Okay. This is the battery and the pacing lead. You always look for the number of pacing leads. If you see one, it's a single chamber pacemaker. When you see two, it's a bipolar. Okay. So this is a bipolar, dual chamber bipolar pacemaker. The one lead is in the right atrium and the other lead is in the right ventricle. Okay. What is this then? These ICDs, implantable cardiac defibrillators and pacemaker look similar. How do you differentiate them? You look for the coil around the pacemaker leads. When you see a coil, it's a defibrillator system. Okay. You can look at the previous images. You don't see a coil around a pacemaker. Pacemaker leads don't have coils around them, whereas the defibrillator systems have coils around them. This is a single chamber defib, and this is a dual chamber defibrillator. You can see coil around the right atrial lead as well as a coil around the right ventricular lead. Okay, coils help you in differentiating between a pacemaker and a defibrillator. This one has a extra pacing lead in the left ventricle. Okay, it's a cardiac resynchronization or a biventricular ICD. Okay, you see, other than the 2 pacemaker leads and the 2 coils, you see one more lead in the left ventricle. Okay. What is this? Only one is left. What is this? It's an implantable loop recorder. Okay. You don't mistake it for a cardiac pacemaker or a. Are these MR compatible? Can a patient with an implantable loop recorder undergo an MRI? They can undergo. Only thing is the MRI will. Only thing is a loop recorder will record the MRI signal as a arrhythmia. Otherwise, you don't have a contraindication for a patient with a loop recorder to undergo a MRI. And this one is similar to this, but a smaller one. This is a. Okay, this is a leadless cardiac pacemaker introduced as late as 2015. There are only 2 in the market by Abbott and Medtronic. Okay, this is a leadless cardiac pacemaker. And when you evaluate for the integrity and position of CAEDs, look for the position of the pulse generator, position of the pacemaker lead, integrity of the leads, look for any thoracic or cardiac complications. This is the normal position, right atrial and the right ventricular lead, and the lead should be pointed anteriorly. Okay, this is the ideal normal position. Again, this is the normal one. Here, your right atrial lead has gone down. Okay, this is the abnormal position. And this is the case of, there's a discontinuity in the lead, it's a lead fracture. Another one, there is extensive coiling of the lead. It's a Twiddler syndrome, when the patient keeps on manipulating the battery. Okay, and to end, I think this is the end. Okay, this is the flow chart for a decision tree for differentiating cyanotic and non-cyanotic heart disease. Okay. Thank you again, madam and KMC team for this opportunity. Thank you.
Thank you, sir, for the illustrative and mind-blowing session. I now request Dr. Geeta ma'am to felicitate Professor Dr. Venkataraman, sir.